Hi everybody, Dr. Adam Smith from Ultimate Bariatrics here. We're trying something new. We're going to try to do a virtual consultation so you can see ahead of time what a consultation might look like should you choose to come see us in the office or do a visit. So please understand that nothing that we talk about here substitutes for medical advice or information, all of the disclosures. This is general information only, but this will somewhat resemble what a consultation might look like should you choose to come in and see us. Ultimate Bariatrics is a comprehensive metabolic and bariatric practice. We do surgical and non-surgical weight loss. We monitor our patients for life. We maintain support groups, support staff to make sure that you have a good long-term outcome. So when a patient comes in to see us, the hardest thing they decide is to make that decision to come in, to accept the fact that you've joined every gym, you've done every diet, you've tried everything humanly possible, taken supplements, taken shots, taken diet pills, and still are suffering from your metabolic disease due to your weight or your weight in general or a variety or combination of things. So when a patient comes in, of course, first thing, we get to know you, Who are you? Where are you from? Are you who you say you are? Which doctor do you want to see? So we don't assign people to a doctor. It's up to you. And pretty much you can pick whichever physician you want to see or whoever's most available. We can all take care of you comprehensively. So let's assume that I got lucky and you chose to come see me. So you'll come in, you'll check in, we'll get your vital signs, your age, your weight, your information. We get your insurance information if you're fortunate enough to have insurance coverage. We will verify those benefits for you. You give us your information and we will do the homework to verify to see, do you have coverage, yes or no? If I do have coverage, what's my copay, what's my deductible, what is my personal obligation? Is there a preoperative program? Is it a 3-month? Is it a 6-month? Is it a 9-month? What kind of hoops do we have to jump through to make sure that you have a positive and effective experience during your weight loss journey? So you've checked in. Hopefully you didn't wait too long in the waiting room, because I lose my mind when people are in the waiting room a long time. And you're placed in a room, and the doctor will come in, introduce yourselves. Sometimes you will see a medical student. We have medical students that shadow us from time to time. You always have the option to not see the medical student, but all they really are doing is sitting there learning and watching, so pretty harmless. So for better or worse, there's a whole lot of different operations out there that we didn't used to have. When I first started doing this, we only had 3 choices. Now we have a half a dozen. So how in the world do you and I, as a team, come up with a procedure or a medical plan that's unique and successful for you? The first thing we like to look at is something called body mass index, BMI. All that really is a mathematical relationship of your height to your weight. As a general rule, the higher the BMI, sometimes the more aggressive operation patients choose. Every surgery we do has a minimum BMI that you have to be considered appropriate. None of them have a maximum. Even someone that is 400 or 500 pounds can do the simplest operation. Now, they may not lose as much weight as someone that does a more aggressive operation, but it may be enough for them. So I don't pick your surgery for you. I try to get to know you as a patient to see what your goals, your health, your risk, and your tolerance of side effects are to find something that gets you where you want to be. So we look at that body mass index. Like the lowest body mass index that we even consider doing surgery on is a 30 for a surgery, or a 27.5 if you are of Asian descent, because your metabolic effects are more significant. So we can go as low as 27.5% for that. Balloons start between 27 and 30 BMI and go up, and we'll talk about balloons in a little bit. Then the lap band starts at a body mass index of 30 if you have comorbidities like sleep apnea or hypertension or diabetes. Same thing with sleeve gastrectomy, and generally speaking, it needs to be a 30. But remember, these are just general thoughts and guidelines. Every case is unique, every case is special. That's why an individualized consultation is so important. So a sleeve, if you don't have any, if you're lucky enough not to have any comorbidities, usually starts at a body mass index of 35. And then we move on to the next stage, which is what we call the gold standard of bariatric surgery, the gastric bypass or the laparoscopic Roux-en-Y gastric bypass. We don't call it the gold standard because it's better than anything else. We call it the gold standard because it's been around a long time. And that starts at a body mass index of 35, 40 if you're fortunate enough to not have any comorbidities. So we're going from least aggressive like a balloon or a lap band to a little bit more aggressive like a sleeve to a little bit more aggressive like a bypass. The bypass is a really good operation for our diabetic patients because of the nature of the operation. We get really, really good diabetes improvement. But then that's pretty much where we stood for a long time. And then we had a handful of patients that just wasn't enough, or they needed more, they needed something else. So there's a lot of newer, more interesting things. We have one that we call the nuclear option, which is Dr. Roberts' favorite surgery, by the way. And that is called the biliopancreatic diversion duodenal switch. Man, that's a mouthful. That is the most malabsorptive operation that we perform. So that tends to start with people who have body mass index over 50. So we're getting a little bit heavier and heavier as we go to more aggressive operations. So the upside is it has the highest percentage of weight loss of any of the operations we do, but it also has more side effects, and we'll talk about those in a minute. We have some newer operations that are really, really exciting. One of the downsides of the traditional laparoscopic Roux-en-Y gastric bypass was when we start rerouting that intestine, you can have a risk of a small bowel obstruction. That can happen one day post-op or 25 years post-op. So there is an operation that is becoming more and more and more popular right now, and I really love it. It's called the one anastomosis gastric bypass. Some people call it the mini gastric bypass. It's really not that new. It's just now started to be popular. There are surgeons, one of the surgeons I went and observed has done thousands of these things over the last 20 years. But here in the Metroplex, we've only really gotten popular in the last 5 years. It pretty much gives you the benefits of a traditional gastric bypass with a lower risk of bowel obstruction. So that makes me happy because I don't like having to operate on people with bowel obstructions unless I absolutely have to. So that is kind of currently my favorite bypass. The downside is not every third-party carrier or insurance company recognizes it, even though it's recognized as mainstream by our specialty society. Insurance companies typically lag years and years and years behind on those. And so we've got our balloon, which is the least aggressive, then our band, then our sleeve, then our two bypasses, the OAGB and the Roux-en-Y gastric bypass. We have our duodenal switch, same issue with the duodenal switch that we had with the traditional Roux-en-Y gastric bypass. There's always a risk of a bowel obstruction. So there is a hybrid operation that is starting to become very, very popular called a SADE, or a single anastomosis duodeno-ileostomy. So instead of dividing the bowel and hooking it up to the first part of the intestine called the duodenum, we bring a loop up and hook it up. These are done, everything we do is done laparoscopically with or without the robot, depending. So small incisions. We don't do anything open anymore if we don't have to. So here we've gone from least invasive to more invasive. The advantage of the SADE, it gives us better weight loss than a traditional bypass, better weight loss than a sleeve, better weight loss with a band, better weight loss of the balloon. You have a few more side effects if you're not very compliant. If you eat a diet too high in fat, you can have some foul gas and some loose stools. Same thing with the duodenal switch. And if you're to the extreme, if you eat too many carbs and starches and stuff, any of these operations can give you an upset tummy and cause some lesser desirable side effects. So how in the world do you decide? So we look at your BMI. How much weight do you need to lose? We look at previous abdominal surgery. If you've had a lot of surgery in your abdomen, some of these more aggressive operations are higher risk, and it can get to the point where the risk may actually exceed the benefit, right? We don't want to do a surgery on you that's going to cause you long-term harm. The third thing is, how much weight do you really need to lose? Statistics are meaningless on an individual basis, but we do have statistics. They apply to groups of people. And we know statistically, the more aggressive the operation, as a general rule, the higher the rate of weight loss. So our job as a team, you as the patient, me as the physician, is to come up with a surgery that gets you to the point where your health is improved, your lifestyle is improved, but we haven't done something so radical that you wish you hadn't ever had surgery in the first place. Because what I don't want at the end of the day is a teeny, tiny, skinny, neurotic patient that wishes they had never had surgery before. You know, at the end of the day, we want your lifestyle and your health to be improved. And that only comes from having a one-on-one conversation and looking at all your risk factors, your weight loss and metabolic needs, your overall health condition, your risk for anesthesia, your risk for hospitalization, and your longevity, and where are we headed. So you can stop me during these conversations at any time if you have questions. Otherwise, I'm going to kind of go through most of the operations we do, tell you how they work, the pros, the cons, the advantages, and the disadvantages. These are opinions. These are not medical facts, and once again, do not substitute for medical advice. So let's start with the balloon. The Orbera intragastric balloon. We were in the FDA trial for this. It was really exciting. The best part is we got to go to Rome to learn how to do it. That was really cool. And I thought, this is silly. This balloon goes in for 6 months, then we take it out, everyone's going to gain their weight back. In fact, that has not been our observation. Less than 25% of people that lose weight with their Orbera balloon gain their weight back. It's done endoscopically, no incision. We bring you in, we put you to sleep, we put the balloon down endoscopically into your tummy, fill it with saline, you go home. The balloon stays in 6 months. After 6 months, we go in, we suck the saline out of the balloon and remove it, and then we continue to monitor you medically for the rest of the year because we don't want to gain that weight back. So, least invasive, but average weight loss, 25 to 40 pounds. So if you're needing to lose 150, 200 pounds, this may not be the best option for you. If you're needing to lose 30 to 50 pounds, this might be a good choice. So then we come to still one of my favorite operations, the lap band. Why is the lap band one of my favorite operations? Because that's what I had. When I was 44 years old, I weighed nearly 300 pounds. And I was already doing bariatric surgery, and I was operating on people that were smaller than me. And I got a call on a Friday afternoon from one of my patients, and nothing good ever happens on Friday afternoon if you're a surgeon. And I said, what's going on? What's the problem? He said, Doc, I'm a year out from my lap band, and I tied my shoes for the first day in 20 years. And I looked down at my feet, and I couldn't remember the last time I could tie my shoes. And I said, you got to do something. And I was terrified because I didn't trust anyone to operate on me other than myself. But I had my band in 2004, lost close to 100 pounds. Over the years, age has got to me. I've put some of it back on. But it's still a very good tool in the arsenal. If you don't want to have your anatomy removed or stapled or rerouted, this can be a good choice for you. There's a new generation of band. It's called the Flex 2.0. I really love it. It's a lot easier to adjust. I think the patients are doing a little bit better. So if you need to lose the weight, but you're terrified of having a bypass or a sleeve or a switch or any of that stuff, a band can be a good option for you. So don't rule it out just because it's not as popular as it used to be. If you are a lot of my colleagues that did thousands of these things back in the early 2000s have now retired. I'm still hanging in there. So if you're kind of someone without someone to take care of your band, we will take you on. Just call the office for an appointment. Make sure if you come in for a band appointment, you come in only on liquids so that we can evaluate the position and orientation and placement of that. So that's the band. Starts at a BMI of 30, but you can go up from there. So the next operation is the most popular operation performed in the United States. It's called the sleeve, or the vertical sleeve gastrectomy. That's an operation that's performed laparoscopically, usually as an outpatient. Of course, there are always exceptions to that. We go in through the laparoscope. We are removing about 60% of what's called the greater curve of the stomach, leaving you a long banana-shaped stomach. So we're reducing volume, but that's just part of the picture. We're getting rid of 60% of the cells that secrete a chemical called ghrelin, which tells your brain that you're hungry. And it also alters some other peptides in the body, which helps with insulin resistance, helps decrease hunger, and helps you lose weight. So it's very popular because it's the easiest one. And we as surgeons like that easy button. And you don't have to be a rocket scientist to know that as a general rule, easier implies safer. Doesn't guarantee it, but can imply that. So sleeve, very popular operation. Then we move into the laparoscopic Roux-en-Y gastric bypass, or the one anastomosis gastric bypass. This is my favorite operation for our diabetics. We see really, really, really good diabetes resolutions with these operations. All of our operations help with diabetes just by the weight loss, but the diabetes resolution with the bypasses is astonishing. And so I don't ever push anyone into one operation over another, but I sometimes will gently nudge our diabetics to consider doing either a one anastomosis gastric bypass or a Roux-en-Y gastric bypass. I'm really excited. I was skeptical about the one anastomosis gastric bypass until I went to North Carolina. I saw this awesome doctor, his name's Dr. Dasher, he's fantastic, perform this operation, and it's a slick operation, and we've been doing it a little over a year, and I think I may never be as good as Dr. Dasher, but I think I got my technique blatantly copied from him, and I think we're doing a really good job with this operation. And now we're going to talk about our more aggressive and more malabsorptive operations, and that is the duodenal switch and the SADE, or the single anastomosis duodeno-ileostomy. These bypass a larger portion of your small intestine. So when we do a bypass of any kind, we have what we call the roux limb, or the alimentary limb. We have what's called the biliopancreatic limb. That is the portion of the intestine that carries your digestive enzymes. And then the third part we have is called the common channel. That's where the digestive enzymes meet with the food, and that common channel is where digestion occurs. In a traditional mini gastric bypass, one anastomosis gastric bypass, or Roux-en-Y gastric bypass, that common channel is significantly longer than in our more malabsorptive operations like the duodenal switch and the biliopancreatic diversion. That's why the weight loss is more rapid. But there is a price you pay. The shorter that common channel is, the more likely chance there is to have some foul gas and some diarrhea. And one of the most common things we see on our Facebook page is stinky toots and diarrhea. So if you're the perfect patient, who I've never met yet, these side effects can be mitigated and handled quite well. If you are a 500-pound patient it might be worth having those side effects to get the weight loss that you need. So statistically, higher percentage of weight loss, a little bit more challenging operation, although we've been doing these surgeries for so long, you know, we would never do them in our sleep, but so to speak. We're comfortable with all of these operations. So from a technical standpoint, you know, most of our bypasses are still spending the night. Our SADIs and our D-switches, most of them are still spending the night. An exceptionally tough character may go home the same day. Most of our sleeve patients go home the same day. Nearly all of our band patients go home the same day. Balloons go home the same day. So it's a tough decision to make, something to talk about with your doctor. Do your homework. If you choose us as your provider, we're going to give you some more homework. There's a lot of stuff on the internet and a lot of it self-serving and garbage, but we have a video tutorial that we send our patients that we stand behind. It's produced by a third party. The information is very middle of the road, very factual, so you can sit in the comfort of your home and learn what you're getting yourself in for. And remember, this is not an emergency. Any kind of metabolic or bariatric surgery should be taken with a cautious, thoughtful approach. And whether you need to see your doctor 1 time, 5 times, or 10 times before you make your mind up, it doesn't matter, because the most important thing is that you make the right decision for you, you make the decision at the right time for you, and that you have a long-term successful journey. What tools do we give you to help you with your journey? We have multiple dietitians on staff that can be seen in the office or televisit. We have a third party that we work with called Virtual Health Partners that provide 24-hour support. They have nutrition, they have meal plans, they have physical activity, they have behavioral counseling, both group and one-on-one, support groups, you name it. And we partnered with them to produce our own app. It's called the Ultimate app. And if you're our surgical patient, we give you that app for free for the first year. After the first year, if you like the app and you continue using the app, there is a monthly nominal charge. We don't make any money off of it. It just covers our expense. And it's very useful. The people, you know, I'm old school, I'm more one-on-one, face-to-face, but the younger generation, they're into apps and it works for them. So whatever tool works for you is the tool we want you to use. So that's our gift to you if you choose to become our surgical patient. We partner with an outfit called SciMed, who does, if you are required to have a preoperative psychiatric evaluation, we always do a brief behavioral evaluation during your consult, right? We're not trying to decide whether you're crazy or not, because I think we're all a little crazy these days. But we're looking for any psychological or sociological factors that could jeopardize your success. Sometimes that involves a one-on-one consultation, either because of your medical history or sometimes just because insurance requires it. Some insurances always require a psych assessment, even if you don't have any psychiatric or sociology history whatsoever. Some don't. We look at the whole patient. Every single patient's different. We don't just boilerplate our process or our approach going through there. SciMed also runs our support group. They're great people. They're very passionate about your success, and they're available for both group and individual therapy. They're not really technically a part of Ultimate Bariatrics. They're just our friends that we use as a third party. We partner with your physician, whether you're under the care of a family practitioner or an endocrinologist or an internist or whatever. We keep the whole medical family in the loop. We follow you forever. A typical post-operative course is you do a 1-week follow-up for a wound check, everything's okay, then you talk to the nutritionist the second week to keep advancing your diet. You see the doctor week 8 where we do a comprehensive lab panel, then we see you at 6 months, then we see you annually forever and ever and ever. We follow your labs every year, forever and ever, because we stay on top of those labs. Not that your primary care doctor doesn't do a great job or your internist doesn't do a great job, but we're very territorial over our surgical patients to make sure that you're staying on track, you're not having any complications, you're not having any vitamin or mineral deficiencies, and you're happy. So that's kind of the gist of how we do a consultation. Of course, we do a physical exam as well. And we include the family. We really like to include your family members in this decision-making process. So we encourage you to bring a significant other in when you come for your consult. If that's not feasible, we can always do a televisit, to get them in the loop as well. So that's the gist of our basic consultation.